Thank you so much, Dr. Neha, for that wonderful introduction. And it is a true honor to be in this room with all of you, celebrating the Dr. Stya Paul IOG Awards, celebrating his commitment to education, scholarship, and dedication to others as we all work to improve the lives and health of those that we take care for, and his work that is honored and shared through this conference, really through the work that all of you do every day. Thank you, Mrs. Stya Paul Awards, for bringing us all together today, for reminding us, each one of us, what each one of us has inside of us. I really appreciated your words this morning. And really for carrying on your father's legacy and the inspiring work that you do. It's been a true pleasure to get to know you a little bit. And to your wonderful family, those with us today, Mr. Nishant Burlia and Dr. Neha Burlia, as well as Mr. Aditya Burlia, I don't know, up there where you're on Zoom, hello. And the teams at Walter Bushnell for your wonderful, incredible hospitality. There are so many wonderful people that I've met while here, and it's been a true pleasure. And then finally, thank you to Dr. J.B. Sharma and the Indian Journal of Obstetrics and Gynecology from the impressive work that has been presented at this conference, both last night and the awards that were presented today. This relatively young journal is flourishing in an incredibly short period of time. And as Nishant pointed out, the research and success in India is really quite incredible. It's impressive, it's growing, and it will be fun to watch in the coming years. Finally, it's been an honor to visit your incredible, beautiful country and soak in the wonderful Indian culture. And with that said, allow me to begin. So why talk about the placenta? There are lots of things we could be talking about. We've heard about some of them. It's key, really, to nearly all pregnancy outcomes for mom and for baby. It's an incredible organ. I could spend all day talking about it, and I'm truly going to distill a lot of information into a very short window of time. Some of it I'm just going to gloss over then very superficially. Please know that that's just an issue of not having enough time to really give this incredible organ everything that it deserves. But if we think about it, it is transient. It appears anew for each pregnancy. It serves multiple vital organ functions at once, and then it goes away, disappears. The work that it does is truly incredible as well. It's acting as the lungs, orchestrating oxygen and nutrient delivery, gas exchange. It is the endocrine system, the source of steroid production. It's storage too. It stores vital substrates that are really critical, nutrients to grow a full-term healthy baby, if we're lucky. It suppresses the maternal immunity, it protects the fetus, and it removes waste. And we heard about some of this last night too, that immune suppression and some of the problems when something goes wrong with it. And in fact, there are other significant consequences when things go wrong. Implantation that is too poor or too deep, and abnormal structure and function can change the maternal and the neonatal life course. And that's what we'll cover today: placental structure and function, detection of placental dysfunction and when things go wrong, the best clinical management with particular focus on placenta accreta spectrum, because that is a lot of the work that I do as well. So I like to think of the placenta as, now I can say, as a deli turnabout, really with constant and extensive interactions coming in and coming out, and yet it all works. I've been impressed driving through these turnabouts. I don't know how you all do it, who drives here. It's very complicated, and yet it does seem to work. It's very impressive, but that's just like the placenta. Everything is entwined. Their inputs into the placenta, their outputs out of the placenta. It absolutely supports life, and it can kill. So first on this slide, if we look on the left, we know that there are a number of maternal health impacts on placental health and therefore pregnancy outcomes. Certain conditions act through the placenta and cause maternal morbidity, and even mortality through preeclampsia, abruption, placenta accreta, and less impactful gestational diabetes. And it can reveal long-term maternal health risks, such as lifetime cardiovascular disease among those with preeclampsia, type 2 diabetes among those with gestational diabetes. And there are other factors that play a role that will impact fetal life, maternal well-being through the placenta as well. Trauma, medications, anemia, nutritional status all impact health via the placenta. And all of it supports neonatal health. Morbidity, mortality through prematurity, growth restriction, and stillbirth. And as an example of that, consider all of these conditions that are associated with fetal growth restriction that is mediated through the placenta. We have the opportunity to modify outcomes by seeing patients with many of these conditions before they become pregnant, optimizing these diseases, and ensuring that pregnancy begins when the disease is quiescent, as well as opportunity to improve outcomes through our clinical management during pregnancy, giving prophylactic aspirin to those at risk for preeclampsia, or controlling blood pressure among those with chronic hypertension to reduce preeclampsia risks. Again, as Nishant mentioned earlier, our knowledge of the placenta has really grown, of anything, through tremendous advances in research and what we have learned in the last few decades. How to improve care through our understanding of its pathophysiology has also grown in recent decades, along with advances in research, things like biopsy techniques that are critically important in understanding that we are getting it right when we draw conclusions within research. Ultrasound, MRI, electron microscopy. And I expect that we'll be seeing exciting advances in the decades to come. It's really exciting to see the young students here, and hopefully they are inspired by this because they are the ones who are going to be doing this good work. And my slide is not advancing. Okay, this wasn't up before. Thank you. Before diving into clinical practice, let's return to some basics: placental structure and function. So this may be quite basic for some of you, but considering the basic structure so that we can level set, the placenta has a maternal surface, as seen on the right, the red part, and then the fetal surface. These are the membranes, the sort of water sac that surrounds the fetus as it's developing. There's the umbilical cord that has 2 arteries and a vein, and it's protected by a thick substance like an insulation cord that's really critical to protecting those small vessels. So if the cord twists too much, we know that can lead to a stillbirth. Sometimes fetal growth restriction is reflected in poor development here as well. So for cellular structure, there are 2 cell types that are given that progenitor cells give rise to. The syncytial trophoblast, as you heard, creates peptides and hormones, especially progesterone for pregnancy maintenance, as Dr. Jha pointed out, gas exchange, and a protective barrier function. The cytotrophoblast serves more of as an anchor. The invasion of spiral arteries into the myometrium occurs here and under that direction, and also it directs the transformation of those spiral arteries. And in fact, that transformation process is so important that we'll dive a little bit deeper here. That transformation is critical to spiral arteries being converted from high resistance, narrow arteries to really wide bore, low resistance vessels. This is what supports the ability for massive placental blood flow that's required for fetal development. We know that failure of that remodeling is seen more commonly in certain medical conditions such as hypertension, cardiovascular disease, and autoimmune disease. Again, so important to control these before somebody gets pregnant and during pregnancy. We know that failure of this vascular remodeling is associated with early onset preeclampsia, fetal growth restriction, abruption, preterm premature rupture of membranes, all of these placental complications. To meet the needs of a growing baby in a very short order of time, there's constant growth and a huge increase in placental blood flow from about 45 mLs early to 750 mLs per minute at term. And this creates the tremendous potential for rapid decompensation in a postpartum hemorrhage. And I know that this is work that some of you really do in your professional lives and research. So there's so many things that lead to poor placental function or maternal morbidity and mortality that include that incomplete transformation of the spiral vessels, as I've mentioned, placenta accreta spectrum, hemorrhage, and death due to physical and structural anomalies. In addition to that incomplete transformation and that abnormal anchorage, these structural anomalies include things like chorioangiomas that can lead to fetal anemia and high output heart failure. Sometimes a structural problem with the placenta may be bilobed, and if you don't know, a bilobed placenta can lead to poor perfusion and fetal growth restriction. Sometimes there's a sectionturate lobe, an extra lobe of placenta, and if we don't know about that and somebody delivers and it's left inside, that can lead to risks such as maternal infection as well as hemorrhage. And then there's the umbilical cord, as I've mentioned. This is actually part of the placenta too. Sometimes it may contain 2 vessels rather than 3. Sometimes it's inadequately protected. So, and I had mentioned before that hypercoiling of the cord without that protection can lead to stillbirth. And this is real. I delivered somebody about 3 weeks ago where this is exactly what happened. There can be abnormal umbilical cord insertion. Sometimes one of the vessels exits prematurely, called a vasa previa. A velamentous cord, and if that vessel is near the cervix and ruptures, that's called a vasa previa, and that can lead to fetal death. So we aim to identify all of these placentally mediated problems, really to optimize clinical outcome through the basics of what we do every day. And I don't think that that should be underestimated, how important routine prenatal care is. Checking things like the fundal height, vital signs. We obtain a routine 20-week ultrasound. When it's indicated by detection of any conditions, diseases, or anything found on ultrasounds, we get growth ultrasounds. We can do antepartum fetal surveillance with either non-stress tests, biophysical profiles, or umbilical artery Doppler studies, and make a difference to our patients, to their pregnancies, to their babies. And I mentioned before underlying medical disease, and again, I want to emphasize that the more we can optimize our patients' medical conditions before they get pregnant, the better the pregnancy outcomes. We can help the patients as well to understand the potential impact of disease on pregnancy and pregnancy on disease, and again, optimizing their conditions before conception. And this is particularly important to our patients with rheumatologic disease and diabetes, as well as others. We can make medication adjustments if needed in this time frame as well, and come up with a plan for increased surveillance during the pregnancy. Now, routine ultrasound is something that we typically get 20-week ultrasound to really look at the whole system to make sure that there are no fetal anomalies, there's not growth restriction. This is also the time that we will evaluate the placenta, and I'm showing a picture here of a chorioangioma. We saw this in my practice about 6 months ago. I'll talk a little bit more about that soon just because I think it's interesting. But the evaluation on routine ultrasound may be what identifies that further workup that is necessary. Perhaps you identify mesomelia. Perhaps we identify growth restriction, signs of genetic conditions, infections. This is really what can prompt the next stage of a higher level workup and care. When we have concerns for fetal growth restriction, this may arise just through routine prenatal care. It may be suspected if there's decreased fundal height. Typically 3 centimeters behind dates is the minimum recommendation for when one should get an ultrasound. We often use in my practice 2 centimeters. Certainly, if somebody has risk factors such as medical conditions, such as prior growth restriction, that's a big one, we will then get serial ultrasounds to estimate the fetal weight, the amniotic fluid volume, and typically we'll do this about every 4 weeks, starting at 26 to 28 weeks. And then when growth restriction is confirmed, that's confirmed if the estimated fetal weight overall is less than the 10th percentile, or now we follow ACOG guidelines, and if the abdominal circumference is also less than the 10th percentile, then that is the diagnosis of growth restriction. We then measure the fetus about every 2 weeks, 2+ weeks, so the recommendation is every 2 to 4 week cadence. Follow with umbilical artery Dopplers as well, and the frequency is really going to depend on the results and the setting. We utilize antepartum assessment in my practice too with non-stress tests, often 1 to 2 times per week in these settings, or one can use a biophysical profile as well. This allows for real-time fetal management and delivery timing if needed, if you see a non-stress test like the one that is shown here. This slide is really a review of ACOG's guidance on when to deliver, and it's really driven by the degree of the growth restriction, considered severe if the estimated weight is less than the 3rd percentile, when to monitor for stillbirth, and that's the whole point that we're trying to protect against. But I won't go through this because it's complicated, but I believe you'll have access to these slides. And I mentioned I would discuss the chorioangioma. This is a benign vascular tumor. It's of placental origin, seen in up to 1% of pregnancies. When they're small, they're benign typically. But when they're larger, there's certainly an increased risk for high output fetal cardiac failure or hydrops with increasing size. For management, and this one you probably can't read it, but it was 6 by 7 centimeters, so quite large. We follow them with serial ultrasounds every 3 to 4 weeks when the tumors are small, and then every 1 to 2 weeks for large tumors. If in utero treatment is needed because perhaps hydrops is developing, there are options. They're not simple options, but laser ablation, microcoil embolization, and radiofrequency ablation. And I want to remind that pregnancy is really a window into the future, that placental function. We know that the placenta and the diseases that may arise during pregnancy can tell us risk factors for future cardiovascular disease for our patients who have preeclampsia. This is an opportunity then for providing longer-term care, talking to our patients about the fact that their preeclampsia diagnosis is a risk factor, as we might consider smoking or high cholesterol, other conditions as well. And this might prompt better diet, exercise, lifestyle modifications, and also for surveillance by their primary care provider. We find in the United States a lot of providers are not aware of this. So a lot of internal medicine physicians, it's an opportunity to educate others to make sure that longer term, throughout the life course, these patients are getting the care that they need. Gestational diabetes itself, which is prompted and often driven by human placental lactogen, a hormone that comes from the placenta, is also a risk factor for later development of type 2 diabetes. We screen our patients postpartum really to understand, did they have pre-existing type 2 diabetes when we made that diagnosis in pregnancy? And if so, they can begin treatment. We can also counsel regarding that longer-term risk that they may develop type 2 diabetes, a silent disease, counsel on weight loss if that's applicable, lifestyle modification as well, or simply future testing as well if they screen negative. So I'm going to switch gears quite a bit right now and talk about the deadliest placental disease, placenta creta spectrum. So what is that? As many of you know, this involves abnormal adherence of the placenta villi to the myometrium. It's often diagnosed via ultrasound in patients with prior scarring. It requires specialized multidisciplinary care and surgical management. Again, that 750 milliliters of blood that's passing through the placenta at full term means that this is a very vascular organ and a vascular condition. The prevalence is increasing, unfortunately, and I think that we'll continue to see that increase. Much less common, particularly in the 60s, about 5% when the cesarean rate was about 5% in many places. It's less than 1% today. That is a scary number. Why is it increasing so much? Because the cesarean rate is increasing. And the rate of placenta previa is also increasing. We know that this is driven by things like age, IVF, and some unknowns. Sometimes having even a prior cesarean is a risk factor for development of placenta previa. The median estimated blood loss in a CRETA is 3 liters. That is a life-threatening amount of blood to lose, as you know. In different studies, 95% approximately of patients will receive blood transfusions at the time of an CRETA delivery, and 40% or so will receive more than 10 units, and then approximately 10% will receive more than 20 units. That's a lot of blood to give somebody. That takes a lot of specialty care and understanding of the maternal physiology and some of the complications that can arise just in doing that. This is something you don't want to see at 3 in the morning as a surprise. This is a uterus with I should have asked for the pointer, but there's that big bulgy area on the lower left-hand side. This is a placenta in CRETA, probably per CRETA. There's an area that I can see a little bit of placenta peeking through. And I think it's important to really note that the vessels that come into this uterus at full term have increased in size. About 20% of maternal blood supply is coming to the uterus. That's in contrast to about 4% in somebody who's not pregnant. So that blood volume increases about 5-fold. Surgically, that makes things very challenging. When you're dealing with very large vessels with a lot of flow coming through them, you need to know what you're doing when you're clamping and you're cutting. If you lose one of those vessels, that may cause someone to lose her life. So what causes this? You know, there's been a debate in the field. Is this overly invasive trophoblast? That's supported by the fact that sometimes a CRETA is reported in the setting of no known prior scarring. I think it's important to note that sometimes somebody may not have had a prior surgery. This happened to me in one case where I encountered an unexpected CRETA in somebody pretty low risk that I was delivering at 37 weeks. And when I asked her afterwards, you know, did you have any surgeries? No. And then it was sort of about, oh yeah, you know, many years ago I had an IUD and it got embedded and I had a couple of procedures to take it out, and we're like, aha, that may be the scarring. More recently, there's the notion that insufficiently protective deciduo is probably it. We know that a CRETA is more common if there's scarring, and therefore then there's failure of normal decidualization. You need this sort of decidual layer. It's almost like Velcro, so the placenta can just separate. And this is supported by the fact that we often see a CRETA more in the lower uterine segment. Some of that's because that's where people have prior cesarean scars. But even patients with previa alone and no prior scarring have a much higher risk of placenta accreta, and this is one of the thoughts here. This is a situation where at delivery, experience, skill, and resources matter more than anything. We don't often talk about rates of maternal death, and in accreta, we need to. We know that there's a big range of estimated maternal death, more recently a little bit less than 1% or 0.7, all the way up to 7%. So that's a big range. More recently, there's been the description of something called the Center of Excellence, which would be the optimal center where somebody could have an accreta. This is a center that offers a multidisciplinary team where there's an experienced maternal-fetal medicine physician or obstetrician, or a pelvic surgeon, somebody who's expert in deep pelvic surgery who can really sort of slickly deal with the major vessels. It's a big surgical problem and a vascular problem. An expert anesthesiologist, somebody who's aware of how do you give all that blood to somebody and maintain all of their vital functions in these cases that can involve tremendous instability from quick blood loss. An expert radiologist or MFM, we need somebody who can really make this diagnosis correctly. Interventional radiology, some people have moved away from that. We don't use it routinely in my practice, but it's an important tool to have available. as well as neonatology, because we often deliver these babies early. It's important to have intensive care unit level services, and most importantly, or I shouldn't say most, they're all important, but blood transfusion services. So having a massive transfusion protocol, cell saver, and transfusion medicine. When it's been studied, hospitals that offer this center of excellence versus standard care, where they don't have all of these necessarily available, showed a 5-fold reduced composite early maternal morbidity, less blood transfusion of greater than 4 units, packed red blood cells, and less reoperation within 7 days for bleeding. That's a situation that in some cases can be very dangerous for a patient. So how well, then, understanding that we would ideally want these patients to deliver in a center that's ready for this, how often or how well do we predict accreta? Well, in some studies that are done in institutions where they're doing a lot of, they've got a lot of referrals for patients with, accreta, and they're reporting really, really high results, that there's high sensitivity and specificity. I don't believe that. And I think you can look to prospective cohort studies to really support this. We know that in the Nordic countries, they had a very large prospective database of all obstetric outcomes. And they found that in 71% of the cases, accreta was diagnosed at delivery. So most cases were not known. There have been several retrospective cohort studies looking in pathology databases. So take all of the hysterectomy samples, the unplanned hysterectomy, cesarean hysterectomy samples, and look at the pathologic diagnosis. In one, I think at Northwestern, 76% were diagnosed at delivery. So we did the same kind of exercise in our own hospital, and we published this work and looked into our pathology database, and it identified something similar, that in the case of 47% of accretas were diagnosed and identified at delivery, it was less common for increta, and we didn't have any cases of percreta. Those were all known. One that gets commonly missed is the microscopic accreta, where essentially there's some fibers, myometrial fibers on a placenta that delivered normally. So antenatal diagnosis is critical for delivery location, really for this specialized care and timing of delivery. So how do we optimize then the diagnosis of placenta accreta? Well, the most important factors here are going to be patient history and risk factors. We've looked at a lot of things, biomarker investigations. A lot of people are very familiar with alpha fetal protein, or AFP. We know that elevated AFP is associated with an increased rate of accreta. We did similar work with PAP-A in my own institution, and we know that if PAP-A is very low, that correlates with fetal growth restriction and poor implantation. So then we hypothesized that perhaps high PAP-A is going to be associated with accreta, and it is. The problem here is, at what level do you really know that there's going to be accreta? It's a little bit messy. Some people have high AFP, very high PAP-A, and there's no accreta, or quite the opposite. It goes in the opposite direction, so not very discriminatory. I've also done work with metabolomics. The metabolome is going to reflect the final downstream product of gene transcription. We found some interesting findings, and it's an area for further investigation. But again, these are not tests that really are discriminatory, that can help us to discern that this patient has it or this patient does not. The most frequent, the most important, the most significant risk factors are going to be whether or not someone's had a prior cesarean and how many, and do they have placenta previa. We know that cesarean alone is not often going to cause an accreta, but once you couple just one prior cesarean with a placenta previa, then that risk really jumps, and that's where this patient deserves targeted ultrasound, and even serial targeted ultrasound looking for signs of placenta accreta. Certainly it jumps a lot more with 2 and 3 prior cesareans. There are many other risk factors. They're not as strong, but they can happen. So first of all, the highest would be anything that causes deep myometrial scarring, the most common being a cesarean, but myomectomy, if it's through and through. Endometrial scarring can certainly do it. Again, they risk the driver risk is really not as strong here, but thermal ablation, uterine artery embolization, radiation, and Asherman syndrome. We know that submucous fibroids, multiparity, advanced maternal age, IVF are also risk factors, as well as twin gestation. They're not major risk factors, but they are there. So when we think about imaging for placenta accreta, again, trying to make that diagnosis in advance, ultrasound is the gold standard. We perform serial ultrasounds if they're risk factors for accreta. I've seen, I can remember one case so distinctly that she had so many risk factors, and her images at 20 weeks looked fine. They looked fine at 28 weeks. And then by 32 weeks, we saw a pretty extensive diffuse, what turned out to be percreta. We could not see it earlier. We even went back and reviewed the images. This one changed over time. MRI may be useful as an adjunct to ultrasound, certainly when there's a posterior placenta in somebody who's got clinical risk factors for placenta accreta spectrum, because the MRI can see the posterior portion where the ultrasound, you have the baby in the way. When there's concern for involvement of the bladder, it's a consideration, or other organs, or when you've got very inconclusive or challenging ultrasound with, say, a patient who has got an elevated BMI and it's just very difficult to see. The optimal timing for an MRI is between 28 and 32 weeks. I think it's important to note, though, that ultrasound and MRI, when they've been compared, ultrasound is either slightly or substantially better. It has better sensitivity and specificity than MRI. And again, MRI might help you with that posterior placenta, the large BMI, patient with a large BMI, or inconclusive ultrasound. But I know that there are some centers who have abandoned MRI. The question arose in one study, is MRI helpful if the ultrasound is inconclusive? And in a very well-done study, they found that ultrasound actually usually had the right answer, and that MRI more frequently either incorrectly changed the diagnosis or agreed with the diagnosis correctly. But because it more frequently led the providers down the wrong path, people have moved away from that, and the cost, some have thought, is not justified. We don't have a good prospective randomized trial on this. Someday, hopefully, we will. When we think about timing of delivery, it is recommended to do a planned early delivery in those with suspected placenta accreta spectrum, as well as placenta previa. That placenta in the lower uterine segment, we know patients who have that will bleed. So in this, we weigh that risk of maternal hemorrhage and morbidities that can lead to, as well as the risk of delivering in a suboptimal location if you don't deliver early enough. Against the neonatal risks, the risk of prematurity is really what the cost is here. But if mom hemorrhages, then baby pays the price there too. And based on this data, in the US, the NICHD has recommended this time frame for delivery, and this is what we follow. So you heard earlier that I founded this Stanford program in placental disorders in 2010. Our goal is really to minimize morbidity, mortality, and do this through standardized care. I think standardization of care is really critically important, particularly in these conditions that require a lot of individuals to get our patients through them safely. But standardization of how we diagnose accreta and how we treat it, as well as care coordination. We also researched the problem of accreta, so we obtained funding early on through an internal mechanism. This allowed us to create data banks and tissue banks so that we can then use those tissues. For example, for a metabolomic work, we have a lot of serum samples, a lot of placental samples, and we're part of the National Accreta Consortium as well, where we all collect data and tissue in relatively similar manner. So we've had some publications with a large number of patients. Our protocol for evaluation of the placenta at Stanford is that we give instructions, first of all, to all patients to arrive with a full bladder. That is really critically important. It sounds minor, it's not. Sometimes you really can't see an accreta because the patient's bladder is empty, and you need this acoustic window, particularly when you've got an anterior accreta. Our sonographers use standardized settings for the Doppler settings on the machines. That's also very important. In doing that, we've had fewer overcalls. When you just turn Doppler ultrasound on, you can make anything light up. And as somebody said, you can Doppler a nosebleed. You can a very slow vascular flow. If your settings are too high, then it can look like a big vascular area, and perhaps it's very lightly vascular, not on accreta. And so getting those settings standard is really important. We also require that our sonographers comment on several things: the lacunae, how many there are they there, and how do they look? We take peak systolic velocity within the lacunae. We look at the retroplacental clear space. Is it normal or absent? The uterine serosal bladder wall interface. Is it thickened? Is it irregular? Is it vascular? We look for irregular placental vessels that are crossing tissue planes and need to comment either that they're present or absent. The placental location, and then finally, the person doing the ultrasound needs to weigh in on their impression. I don't know if you all get these reports, but I've had reports that come back and say, well, yeah, maybe there could be an accreta. And that's not helpful when you're going to the operating room. We want to know, is there a high suspicion for accreta, a low suspicion, or that there are no sonographic signs of an accreta? And it's always best to either do the ultrasound or speak to the person who's doing the ultrasound. I want to shift and talk a little bit about our preparation at delivery. This is an area that really we should not be lone providers for. It takes a village, and the list on the right includes everybody that participates in these deliveries. Maybe not every time. For example, urology often doesn't come in as much, or vascular surgery. They've come in before. Trauma surgery has come in before. During pregnancy, we always obtain consultations with maternal-fetal medicine, obstetric anesthesia, gynecologic oncology, neonatology for the planned prematurity, and social services. And some of that is for relocation. Our hospital actually helps to support patients who can't pay to relocate from far areas and stay near Stanford until they deliver, because if they go into labor or bleed in their local communities, they don't have providers who can handle this condition, and that could be associated with death. We assess for and correct anemia, admit patients to the hospital by 34 weeks, because with the previa, that's when the bleeding risk starts to increase. And our delivery timing is 34 to 35 weeks and 6 days, or urgently if there's hemorrhage or labor. We also send an email announcement out, so everyone in the hospital knows. There's about 80 different providers on this list, and all teams are aware when a patient with an accreta is delivering. Intraoperative management before delivery includes, in the operating room, ultrasound mapping to identify where is the placenta, so we know how high we need to cut, cystoscopy and ureteral stent placements, neuraxial anesthesia. We typically have the patients awake during the delivery of the baby so that they can meet the baby, with then conversion to general after delivery. We make a vertical midline incision on everybody. This, when you're deep into that pelvis, you need the exposure, but very often, such as the image in the lower right-hand side, you need to get above the placenta, and sometimes we're cutting a fundal hysterotomy, or I've even sort of delivered the whole uterus out and made a fundal posterior hysterotomy to deliver the baby, depending on placental location. You can await placental separation, but it's important, as you know, to avoid manual separation. You don't want to go and try to peel it off. That will lead to massive hemorrhage, and that will lead to a patient that can quickly become unstable. And then after closure in our practice, and this may differ, we step away, and the gynecologic oncologist will lead the hysterectomy. There's a lot of preparation for the hemorrhage that we can expect. So in the room, we have 2 massive transfusion protocol cross-match equivalents. We have a lot of IV access, including an arterial line, a central line, and additional access is needed. This allows us to give blood to a patient who's hemorrhaging very quickly. For that purpose, we also use something called a Belmont infuser. You may have that too, but this is one way to get blood again into a patient very quickly. For location, if we are concerned that there is a percreta, we will perform the surgery in a place where we have access to transesophageal echocardiogram as well. In my institution, that means a cardiac anesthesiologist. So we go to a different operating space if we are not in an emergent situation. It's important to remember that if you're transfusing blood, it's important that you continuously look at the electrolytes and replete them. We know that Calcium in particular is important to replete if a patient is receiving large amounts of transfusion, because the citrate can make somebody hypocalcemic, and you can have a hypocalcemic arrest if you're not looking for this. We also redose antibiotics every 1,500 cc's of estimated blood loss, or every 3 hours of surgery. What do you do if the bleeding doesn't stop? Well, people have reported, and we've done pressure packing with laparotomy sponges. You can clamp. Interventional radiology can still be called in at this point. Infrarenal aortic compression can be helpful. Sometimes you just need to slow the bleeding enough to let the anesthesiologist catch up. Perhaps the patient's in DIC, perhaps she's unstable and you need a little bit more time to temporize. Balloon occlusion is a possibility too, or clamping of the aorta in extreme cases. You have to be very careful because there's a risk of distal thrombosis and ischemia, or sometimes the balloon being placed too high. Calling for help. One of the most important lessons I had was when a trauma surgeon showed up to the room, and we were in a bad place, and the patient had coded from the amount of blood loss. And he showed us a new technique, which I'll show you. And so I said, call this know when to walk away. This is interval stage surgery. This is a patient with a lot of clamps. Her uterus was out. It had been out for a long time. And because of this lateral vascular problem that accreta presents, she had consistent, persistent, life-threatening hemorrhage that continued from her pelvis. There was nothing really that one could sew. You can't suture through just this giant kind of venous plexus stuff that's bleeding. So you can pack that. In this case, we clamped a lot of things and then left her open, closed over what looked like a just giant plastic wrap to keep everything stable, sent her to the intensive care unit for very close monitoring overnight, and then returned the next morning to a nearly bloodless case. Her body needed just time to catch up, and that was truly a life-saving maneuver that was brought to us through a trauma surgeon, an experience that they have in trauma surgery. Postoperatively, these patients frequently receive ICU admission. They need observation very closely to correct that coagulopathy or anemia. It's important to watch for ongoing bleeding or any kind of injury that comes with massive transfusion, renal tract injury, organ dysfunction, Sheehan syndrome, pulmonary edema. You guys have probably heard of that, transfusion-associated lung injury, particularly with these massive transfusions. They're at risk for pulmonary embolism as well as infection, and have a low threshold for re-exploration if there are any concerns. They often will need lactation support. They can lactate and breastfeed, and we've had lactation come in and start the pumping process even for a patient in the intensive care unit who's intubated. We know it's very important to continue to address psychological distress, that tender loving care. We know that when these women are, sitting during pregnancy, knowing that they have this life-threatening mountain ahead that they need to get through, that may leave their children motherless, it's very much, it leaves a pretty deep psychological scar that doesn't go away. And I've heard one patient describe it as, after delivery, it's not over for us. And many people carry that distress throughout their lifetime, and it's really important to address it. A wonderful organization that does this is the National Accreta Foundation. If you Google that, you will find a lot of patient-driven educational materials that are well curated. And I refer a lot of my patients there because there's a lot of patient stories. Again, it's all curated, and it's much safer than kind of the wild west of the internet when patients Google accreta and they find all sorts of very scary stories. I would be remiss if I didn't comment on prevention. Avoiding the first cesarean is the most important thing we do. Caveat is when possible. There's a really truly important time and a place for cesarean. If it's overused, we will see more accretas. So some parting thoughts on placenta accreta spectrum before I conclude. Just would like you to remember that patients with significant risk factors should undergo serial sonography, looking for signs of an accreta. They should have a full bladder. Well, if you're assessing for accreta with previa, we actually will bring people back if their bladder is empty. and try the scan again. They should deliver in well-resourced environments with an experienced multidisciplinary team that has the right expertise and, again, the right resources, particularly blood. You want to optimize hemoglobin during pregnancy, have a backup plan in any smaller institution that encounters surprise accretas, and research the problem. Overall conclusions, I'd like to just remind that key principles are that a healthy placenta is really important to healthy outcomes. We know that the importance of controlling medical disease before and during pregnancy, serial fetal screening for those at risk, and delivering the best setting for the patient and the newborn. Finally, pregnancy outcome provides a window into that future, so remember health surveillance for those who have preeclampsia and gestational diabetes, and we can improve lives and health and well-being this way. So thank you so much for listening, for your engagement, and thank you.